Having a diarrhea is a very unpleasant feeling. What more if you've been having it intermittently for more than a year? Today we have a case of an 18-year-old girl presenting with chronic intermittent diarrhea, and this is her story.
Hey guys, so I'm actually at the hospital today. So I actually consulted my doctor this morning since I've been having these rashes on my legs lately. This was after I've had an upset stomach, which I really had to go to the bathroom several times. So they actually just prescribed me with some medications. If I'm not mistaken, it's cotrimoxazole. Yeah, I'm not sure, but I really hope it's effective. So see you guys around. Hey guys, what's up? So I just went back to my doctor this morning since I've been having this diarrhea again lately. I'm not really sure why, but I think they tested me for TB exposure. I'm not sure if you could see it, guys, but yeah, they said it was negative. However, they prescribed me with anti-TB drugs that I need to take for 6 months, but I don't even have a cough, so I'm not really sure why. So what do you think, guys? Put down your comments below and let me know. I'm really sorry if I'm not able to update my vlog recently due to health issues. So I haven't been feeling really well. I've had fever and my diarrhea's gotten worse, and I'm having this crampy stomach pains all the time. I'm even having a hard time sitting down, so I think I'm scheduled for a CT scan this week to find out what's really wrong with me. So I'll be gone for a while, okay? So I'll miss you guys. See ya. So after being in and out of the hospital for several times, I am finally back at school. So I've been feeling really well lately, and I think that the medications that they gave me actually worked. So I'm finally back at school. Say hi, guys! Hi! So see you around. You know, guys, I've been having a really tough time lately. I had to go back to the doctor several times, and this time they did some lab workups and said that I was positive for cryptosporidium, if I'm not mistaken. They actually advised me or prescribed me with erythromycin, and so far I've been feeling okay. So I just really hope this works because I'm really tired and really frustrated about my situation right now. Tired and weak. Yeah, that is how I've been feeling lately. I don't know why, but I feel bloated and I'm not in the mood to eat. Maybe because of the stomach pains I've been having all the time. My diarrhea actually came back again, and I've been having a really hard time. It doesn't seem like it, but I already lost a lot of weight. They actually prescribed me with some antibiotics, but I don't think it's effective because nothing has changed much. So I think they're going to refer me to another doctor. So tomorrow I'll be checking out another hospital, so let's see how it goes.
With regards to the patient's history of present illness, we shall now present some differential diagnosis as to the patient's clinical condition. The diseases associated with chronic intermittent diarrhea can be divided among infectious as well as non-infectious entities. The former includes bacterial colitis as well as gastrointestinal TB. On the other hand, Crohn's disease and ulcerative colitis are the primary non-infectious diseases under consideration. Bacterial colitis was considered due to the cardinal manifestations of abdominal pain, mucoid watery diarrhea, as well as intermittent fever. However, the spectrum of illnesses is doubtful due to the fact that they are often self-limited and would normally respond to empiric antibiotic therapy. Additionally, they are less likely to present with chronic intermittent diarrhea. A stronger deliberation is gastrointestinal TB due to the aforementioned symptoms. Tuberculosis is known to mimic manifestations of many other illnesses depending on the focus of infection, and systemic symptoms such as intermittent fever, anorexia, and gradual weight loss also support such a diagnosis. However, the persistently negative PPD result makes this less plausible. GITB is also predominantly found in immunosuppressed and/or HIV patients, and it most commonly involves the distal ileum, both of which are not evident in the patient's clinical picture. CT scan findings of the patient revealed that the transverse colon was affected by the pathological process, and that treatment with anti-tubercular therapy did not prevent the recurrences exhibited in the history of the present illness. Ulcerative colitis and Crohn's disease present with similar clinical manifestations. However, there are important differences between the two which may help in clinching the diagnosis. For instance, systemic symptoms, secondary infections, in this case, Cryptosporidium species, as well as the absence of bloody diarrhea, all point to Crohn's disease. The patient had undergone a fistulectomy during the course of the illness. Abnormal tract formation involving the affected areas is more frequently found in Crohn's disease. Laboratory tests, as well as imaging modalities, may better help in distinguishing between both clinical entities.
To narrow down our differential diagnosis, we will now go through our patient's course in the ward as well as her laboratory results. On the first hospital day, venoclysis was done to administer the following medications. Metronidazole 250 mg every 8 hours is a broad-spectrum antibiotic used to prevent and treat infection of wounds and abscesses. Metronidazole can be used to treat inflammatory bowel disease in a range of circumstances. For example, it can be used in the following: to treat people who have active mild or moderate intestinal disease, to treat people who have perianal disease, and for people who have just had surgery for inflammatory bowel disease. Ranitidine 50 mg IV every 8 hours is a drug belonging to the class of histamine 2 blockers, which works by inhibiting the action of histamine on the cells, thus reducing the production of acid by the stomach. And the patient was also given paracetamol 500 mg 1 tab every 8 hours as needed, given for the patient's febrile episodes.
On the second hospital day, we were able to get the laboratory results of the patient's CBC and chemistry tests. We have decided to perform CBC because we are concerned with the possibility of the patient having any signs of infection or anemia. CBC revealed that the patient has hypochromic microcytic anemia as evidenced by a low MCV and MCHC and hemoglobin count as well as hematocrit count. This type of anemia may suggest the possibility of anemia of chronic disease, thalassemia, iron deficiency anemia, or sideroblastic anemia. In the case of our patient and her clinical manifestations, anemia of chronic disease seems more likely. Platelet count is increased in patients with inflammation due to the influence of inflammatory mediators in thrombopoiesis. If our patient is suffering from an inflammatory condition, thrombocytosis may be present. The patient's white blood cell count is slightly elevated with neutrophilic predominance. It suggests a possible bacterial infection. Acute phase reactants, ESR and CRP are elevated, clearly suggesting inflammation. For the chemistries were performed because we are concerned with the possible electrolyte loss in this patient. Another reason is that in IBD or inflammatory bowel disease, comorbidities such as autoimmune hepatitis and primary sclerosing cholangitis may be considered. Some alterations in lab tests such as liver function tests may also be secondary to hepatotoxic agents used in this patient. Chemistry results revealed the following: hypokalemia and hypocalcemia. The patient's electrolyte imbalance may be due to her chronic diarrhea. Low serum calcium levels may be due to malabsorption. ALP or alkaline phosphatase. Alkaline phosphatase values were elevated. It is a marker of biliary dysfunction. Increase of ALP 10 times the upper limit of its normal value may indicate presence of obstruction in the ducts, infectious process resulting in ascending cholangitis, or a space-occupying lesion. If we consider inflammatory bowel disease, this may prove to be helpful since Crohn's disease may present with primary sclerosing cholangitis as a comorbidity.
For these findings, the following medications were given. For the patient's hypokalemia, potassium correction was done. For the patient's hypocalcemia, calcium chloride 1 ampule IV was given. Methylprednisolone 60 mg IV every 8 hours for 3 doses was given, and this is a corticosteroid to suppress the immune system and decrease inflammation. Hyoscine N-butyl bromide 5 mg every 6 hours as needed was given as an antispasmodic for the patient's abdominal pain, and ranitidine was shifted orally 150 mg twice a day.
For the third hospital day, for the imaging of the alimentary tract, gastroscopy, colonoscopy, and small intestinal series were requested because it will allow the physician to determine the site of involvement and might also help him to administer proper medical intervention. With the consideration of inflammatory bowel diseases, inflammation may be evident on certain parts of the colon. Imaging studies may help rule out one inflammatory bowel disease over the other. These are the following results. For the gastroscopy, the results are normal, status post-biopsy. For the colonoscopy, there is segmental colitis, probably Crohn's disease, status post-biopsy. And for the small intestinal series, the results are also normal. Cardiolipin antibodies were also requested, mainly because we consider an autoimmune etiology for the patient's condition. However, the test was negative, therefore, we can rule out the possibility that the patient may have autoimmune diseases such as systemic lupus erythematosus or antiphospholipid antibody syndrome. However, if other serologic markers such as p-ANCAS and ASCAS were present, it may support the diagnosis of inflammatory bowel disease.
For the third hospital day, medication given was mesalamine 500 mg per RM thrice a day. It belongs to the aminosalicylates class of drugs and appears to act locally on colonic mucosa to reduce inflammation through a variety of anti-inflammatory processes.
For the fourth hospital day, HLA typing was requested. This was because it may provide important insight on how the disease develops, depending on interactions between genetics and environmental factors. Once the genetic susceptibility of the patient is established, it can aid in the individualization of the management of our patient. The results for the HLA typing are as follows. The results were along the normal range. Serum levels of potassium, calcium, and magnesium were requested again to monitor response to the interventions done on the second day.
On the fourth hospital day, the patient was discharged and was given the following take-home medications. Activated dimethylpolysiloxane was given as a treatment for bloating from excessive gas. Methylprednisolone was still given to reduce the inflammation. A broad-spectrum antibiotic, metronidazole, was still given to the patient to prevent and treat infections in the abscesses or in the wounds. Sulfasalazine 500 mg, 2 tabs thrice a day, which belongs to the class aminosalicylates, was also given to decrease the swelling in the colon.
The laboratory results and imaging modalities requested therefore support our primary consideration of Crohn's disease.
Crohn's disease is a chronic condition characterized by inflammation of gastrointestinal or GI tract. Since Crohn's disease is a chronic illness, it is persistent and will be present throughout a patient's life. However, the patient and physicians can work together to manage the symptoms of this disease. Crohn's disease can affect any part of the GI tract, but the most common location is the ileum and the large intestine, specifically the cecum. Current thinking is that Crohn's disease is a genetic disease caused by abnormal regulation of the immune system. The GI tract is frequently confronted with bacteria on our diet and environment. Many factors can contribute to a person's risk of having Crohn's disease, but most can be thought in 3 categories: genetic predisposition, environmental factor, and the dysregulated immune response in the GI tract which causes inflammation. Environmental factors that may contribute to Crohn's disease includes infection, smoking, and taking antibiotic or anti-inflammatory drugs such as non-steroidal anti-inflammatory drugs. In Crohn's disease, inflammation, ulcers appear within the GI tract, and the immune system works to combat the bacteria and viruses. However, the difference is that the immune system is not able to turn itself off after it has gotten rid of the bacteria or virus, so the ulcer remains until they are treated with medicine or surgery. This chronic inflammation is what causes the symptoms of the Crohn's disease. In Crohn's disease, there is inappropriate innate immune and epithelial sensing, or simply immune dysregulation, that leads to the activation of CD4 and CD8 T cells that altogether secrete cytokines. TNF-alpha is produced, which leads to chronic inflammation, which may result to local and systemic effects. Systemic effects include fever and cutaneous manifestations such as maculopapular rashes. Locally, the inflammation causes damage to the intestinal wall, causing abdominal pain, which can cause anorexia or loss of appetite of the patient, resulting to weight loss. Damaged intestinal walls also cause a decrease in the absorption of water, resulting to diarrhea, which could further aggravate weight loss and decreased electrolytes as well. TNF-alpha also causes the death of intestinal epithelial cells, causing an impaired absorption of nutrients and impaired barrier. This could lead to vitamin and mineral deficiency, which can result to anemia. Impaired barrier alters the microbiota in the intestines, increasing its susceptibility to opportunistic infections. Furthermore, Paneth cells are destroyed, which contributes further to its susceptibility, which may have led to the cryptosporidium infection of our patient. This in turn could trigger a flare or relapse of the condition of the patient.
Inflammatory bowel disease is an immune-mediated chronic intestinal condition. Ulcerative colitis and Crohn's disease are the two major types of inflammatory bowel disease. Peak incidence of IBD such as Crohn's is usually in the 2nd to 4th decades, reporting the highest incidence among those aged 20 to 29 years old. Female-to-male ratio ranges from 0.34 to 1.65, suggesting that the diagnosis of IBD is not gender-specific. Though the incidence of IBD is among white and Jewish people, incidence of IBD in Hispanic and Asian people is increasing. Urban areas have a higher prevalence of IBD than rural areas, and higher socioeconomic classes have a higher prevalence than lower socioeconomic classes. Smoking is also an important risk factor.
Therapeutic recommendation for Crohn's disease depends on the disease location, disease severity, and disease-associated complications. There are two goals of the management of Crohn's disease. First, induction of clinical remission, and the second one is the maintenance of remission. Management of Crohn's disease entails a multidisciplinary approach. For the induction of remission, we may refer to the following algorithm. Treating a person with Crohn's disease encompasses their nutritional, medical, and surgical needs. First, for supportive and symptomatic therapy, patients with inflammatory bowel disease may require symptomatic therapy, particularly when their symptoms are not related to active inflammation. Paracetamol medication as needed for febrile episodes, antispasmodic agents for the crampy abdominal pain such as hyoscine butyl bromide, antibiotics such as metronidazole for prevention and treatment of infection in abscesses and wound sites, And last, avoidance of antidiarrheal agents such as loperamide. For the medical management of inflammation, we have various options and their utilizations depend on the patient's response. First, we have drug therapy with the monotherapy of conventional glucocorticoids. According to studies, budesonide given at 9 mg per day over an 8-week period proves to be effective in inhibiting the expression of multiple inflammatory genes and at lesser side effects. Add-on therapy includes the use of thiopurine agents such as azathioprine or 6-mercaptopurine. These are immunomodulators that inhibit ribonucleotide synthesis and cell proliferation, therefore inhibiting immune response. This is given in the following dosages. Now, if unresponsive or intolerant to conventional therapies such as glucocorticoids, biological therapies may be used such as anti-tumor necrosis factor agents such as infliximab or adalimumab. It works by promoting rapid reduction in the number of cells in the inflammation site, and it is given in the following dosages. It may be given as a monotherapy or combined with immunosuppressants. For surgical management, elective indications for operation include the following: fistula with or without abscess, obstruction, failed medical therapy, malignancy, and growth retardation. For emergent or urgent indications, it includes perforation, hemorrhage, and megacolon. Since our patient does not have any of the said indication, she will not need further surgical procedures.
If the induction of remission is successfully completed, we will proceed with the maintenance of remission, which is the second goal of therapy. It includes the following: maintenance of remission using drugs, maintenance of remission after surgery. Maintenance of remission by drugs and after surgery is done by using azathioprine or 6-mercaptopurine as monotherapy. Studies have shown that the following dosages prove to be effective in maintenance of remission.
Malnutrition can occur both in ulcerative colitis and Crohn's disease, but it's a greater problem in Crohn's disease, given its capacity to affect any part of the gastrointestinal tract. It may be the result of reduced oral intake, increased nutrient requirement, increased gastrointestinal losses of nutrients, and occasionally from drug-nutrient interactions. There is no evidence to suggest that any particular food or diet causes, prevents, or cures inflammatory bowel disease. There is no single diet or eating plan for everyone with inflammatory bowel disease, and dietary recommendations must be individualized. Dietary recommendations are generally aimed at easing symptoms during flares and ensuring an overall adequate intake and absorption of nutrients, vitamins, and minerals. Advices: small, frequent feeding. Avoid trigger foods. Limit food with insoluble fiber, such as seeds, nuts, beans, green leafy vegetables, fruit, and wheat bran. Reduce the amount of greasy or fried foods. It is important to remember that all inflammatory bowel disease patients have different food intolerances. Drink plenty of water. Beverages to try. Water. Low sugar sports drinks. Fruit juices diluted with water. Beverages to avoid. Ice-cold liquids. It can cause cramps in some cases. Caffeine in coffee, tea, and other beverages. Caffeine can act as a stimulant to rev up the bowel and results in diarrhea. Nutritional support. For severe Crohn's disease, bowel rest, which includes no food by mouth except at times during enteral nutrition in the elemental and polymeric forms, may help reduce inflammation and is used in combination with medical therapy. Enteral feeding using formula or liquid should always take preference over parenteral feeding unless it is completely contraindicated. Parenteral nutrition is indicated in inflammatory bowel disease. First, when oral or tube feeding is not sufficiently possible. Example is when the GI tract is dysfunctional or in Crohn's disease patient with short bowel. Second, when there is an obstructed bowel where there is no possibility of placement of a feeding tube beyond the obstruction or where this has failed. Third, when other complications occur such as an anastomotic leak or a high output intestinal fistula.
People with Crohn's disease are also at increased risk of other complications such as osteoporosis, iron deficiency anemia, pyoderma gangrenosum, and colorectal cancer. Osteoporosis is the weakening of the bones caused by a malabsorption of nutrients in the intestine and as a side effect of steroid medication. People with Crohn's disease should eat a diet rich in calcium and vitamin D and participate in appropriate exercise program. Not smoking and avoiding excessive use of alcohol are also important. In some cases, medication to prevent further bone loss may be recommended, especially for those on long-term glucocorticoid therapy. Like Crohn's disease and ulcerative colitis, osteoporosis is a disease with no cure. However, several medications are available for the prevention and/or treatment of osteoporosis. And they are as follows. Iron deficiency anemia is also one of the complications of the Crohn's disease. It is a condition that can occur in people with Crohn's disease because of bleeding in the digestive tract. Common symptoms include tiredness, shortness of breath, and a pale complexion. Treatment for iron deficiency anemia caused by Crohn's disease focuses on replenishing iron stores as well as controlling Crohn's disease. Iron stores can be corrected through oral supplementation of iron or increased dietary intake. If blood loss is severe, blood transfusions may be necessary to replenish the amount of red blood cells in your blood. In addition to replenishing iron stores, it is important to stop the bleeding from the intestinal tract. Another is the pyoderma gangrenosum. It is a rare skin reaction that causes painful skin ulcers in Crohn's disease. Most clinicians use a stepwise approach and both topical and systemic treatments. Immunosuppression is the mainstay of treatment, and the most commonly used drugs are corticosteroids and cyclosporine. Colorectal cancer. Some people with Crohn's disease have slightly increased risk of developing colorectal cancer in later life. Chemoprevention of colorectal cancer remains an important goal, and retrospective data suggests that 5-aminosalicylates might play an important role in this context. Key components in this early detection of colorectal cancer in this patient includes colonoscopy surveillance programs with multiple biopsies performed every 1 to 2 years.
Reproduction or pregnancy. There are no adverse outcomes of pregnancies in patients with IBD who are taking immune modifiers. Continuing the immune modifier throughout the pregnancy is the safest course of action for both the mother and the fetus. Methotrexate is contraindicated due to its teratogenic properties. Oral contraception may have reduced effectiveness. Additional contraception is recommended for women on combined hormonal contraception who are also receiving antibiotic regimens for less than 3 weeks.
Since this is a lifetime condition, the possibility of relapse, failure in medical therapy, and complications is highly possible. Therefore, we may suggest the patient to be a member of Philippine Health Insurance or PhilHealth. In here, we can see that Crohn's disease could be covered. Therefore, she can avail this service if needed.